Greetings. Let me share with you a case of ascending colon polyp resection that was technically challenging for scope insertion as well as resection. So we used a pediatric colonoscope uh, because this patient has had prior failed scope insertion uh, into the colon. And we also encountered angulated and fixed sigmoid colon that required a lot of maneuvering uh, to reach the descending colon. After we reached the descending colon, as we went up, we noticed the preparation was not satisfactory, and this case was done with general anesthesia and given her morphology. After clearing the ascending colon and defining the polyp, we decided to uh, try endoscopic resection. We noticed that the scope movement around the polyp was limited. Every time we tried to push the scope in, we kept falling back. In addition, the referring physician noted a little bit of a depression, and biopsies were taken, and they came back as benign. And the biopsies made resection technically challenging. After injecting saline with a little bit of methylene blue to lift the lesion, first on the distal side, as you've seen, followed on the proximal side, we were comfortable with the lift, although it is not very satisfactory. This polyp is not big. It is flat and it is less than 20 millimeters. Such polyps could be resected using a 15 millimeter snare in an en bloc fashion. So as we were trying to capture the polyp in the snare, the colon was relatively fixed and the scope movements were limited, and as you can see here, I was not able to capture the polyp in the snare despite slow closure of the snare. So we tried gently trying to close the snare and also trying to decompress the colon uh, to reduce the to increase the chances of en bloc resection. So as the initial attempts to approach the polyp from the left side were unsuccessful, we tried to do it on the right side, and we decided that that's not the best attempt. So we went back to the left side for another attempt to remove this polyp. As you can see here, we were able to anchor the snare on the left side, but having trouble with the movements, because as we move to the right side, the center of the polyp tends to fold, and in such cases, when you close the snare, basically the snare will lose grasp of the polyp and the polyp will slip away. So in such cases, one has to rethink the possibilities, and the team decided that we should inject a little more saline to lift the lesion in the center, hoping that we will be able to grasp the entire polyp in one snare resection. So after additional injection, we tried to remove the polyp again with a stiff snare, and we felt that it may or may not be possible, and then we changed our mind to remove the polyp in piecemeal resection. So here we are making an attempt to remove the polyp. Because of the injection, we are able to grasp the polyp, but as you can see here, the central scarring of the polyp tends to tether the polyp, and it doesn't come into the snare as one would expect. So in such cases, one should not close the snare, and the assistant has to work very closely with the endoscopist. So otherwise, you'll cold snare a little bit and the area starts bleeding. So we made an attempt to remove the polyp in a piecemeal fashion after having had no chance to remove it en bloc. Whenever you have limited movement of the scope around the polyp, it is best to cut in small pieces because the chances of deep injury are going to be much less compared to taking or making an attempt to remove large portions of the polyp. So we decided to remove the left lobule of the polyp, which was successful, and then we moved to removing the right half of the polyp. So we used for this resection, for the piecemeal resection, we decided to go with a 10 millimeter snare, stiff snare, and as you can see here, we're able to anchor the snare on either side of the residual polyp and able to snare it, and used Endocut Q313 setting on an ERB machine. Endocut Q3 is effect 3, 1 is duration, and 3 is interval between the cuts. So we are using the current to cut this polyp. So as you can see here, there is some fibrosis underneath that made the cut take a little longer. And after the resection, one has to check the base. You can see nice blue base, but there is some residual polyp on the front side, that is on the cecal side, still there. And this is the polyp that is tethered to the underlying wall and or deep submucosa, and making en bloc resection technically challenging. So we thought that we will be able to resect this polyp like we resected the first two specimens, and we tried with a 10 millimeter snare to resect this polyp, and this was technically very difficult to resect, although the polyp was very small in size. In someone where the scope movement is relatively free and able to move around the polyp easily, and there was no prior biopsies and tethering, this resection could have been done fairly easily and in a very short period of time, not more than 15-20 minutes for resection of such polyps, because these can be resected in block fashion. However, underlying tethering makes it technically very challenging to resect this polyp, and we are trying to see if we could remove this polyp using the snare. We tried several different techniques, but the snare kept slipping back, and we finally decided that we may need to change the technique to remove this polyp. So what we did was we did what we call suction technique. So we went onto the top of the polyp and suctioned it to lift it up, and then try to resect it. Recently there was a technique that was described by Doug Rex about how to remove tethered polyps by applying the snare on top of it and then suctioning and hoping that the polyp will come into the snare and then quickly close, followed by a quick cut. We tried that technique. We tried our own technique, that is, you suction and allow the polyp to come into the cap and wait there, and once you release the suction, get your snare ready for removing the pseudo polyp created by suction. These techniques did not work, and at this juncture we decided to use a heart biopsy avulsion technique. In this technique, you use a heart biopsy forceps and you set your ERB machine to endocut I, not Q, endocut I, and I typically use the settings of 111 or 211 depending upon the amount of fibrosis. Uh, Here the settings were endocut I 111, effect 1, duration 1, and interval 1. So because of the underlying fibrosis, we decided to pick small amounts of pieces and then use hot biopsy avulsion. The technique involves, as you can see here, grasp the polyp that is tethered to the wall, gently lift it away from the muscle, and we'll try it again here. Grasp the polyp and lift it away from the muscle and use endocut high 111 cut. So that means I tap on the yellow pedal, short taps, and then that will cut the scar tissue. So after each cut, make sure that you examine the base so that you have not had any deep injury. So this is the portion that is stuck to the wall. As you can see here, there are a couple of folds coming to the base of the polyp, and whenever you see folds that are coming to the base of the polyp, it indicates that there is underlying submucosal fibrosis. Since the polyp did not have any features to suggest cancer during endoscopy, during the initial evaluation, I don't think we are dealing with cancer, but the pathology will tell us what is happening here. So as you can see here, we were able to remove the polyp that is tethered to the wall using hot biopsy avulsion technique. There is still a little bit of tissue left, and we are trying to grasp that. Sometimes even with hot biopsy avulsion, it may not be possible. As you can see in this case, the polyp tends to slip, and here we grasped a little bit of the surrounding margin and then trying to see if we can cut around that tethered area so that later on we will be able to grasp using the margin created by previous hot biopsy avulsions. So now we are trying to come to the last portion of the hot biopsy avulsion. This is technically the most challenging one, as the polyp is tethered to the wall and doesn't come into the forceps easily. As you can see here, when we try to close the forceps, instead of finding the polyp tissue, we end up holding the normal tissue. So it is important, once you close the biopsy forceps using hot biopsy avulsion, before you apply current, you want to make sure that the polyp is in fact inside the cup or the cups of the biopsy forceps before you apply endocut I111 current. So we spent quite a bit of time to remove this small polyp that was tethered to the underlying wall using a combination of piecemeal EMR followed by hot biopsy avulsion technique. So one thing I need to share with you is whenever I see a patient who is on the obese side and who has a technically challenging insertion as well as resection with the risk of tethering involved, I always try to do those cases with general anesthesia to have a stable operating field. This could not have been possible with just TIVA in my experience because the patients tend to breathe heavily as they were deeply sedated, and the operating field tends to move quite a bit and makes it hard to do precise resection or precise hot biopsy avulsion as you can see here in this case. So something to keep in mind when resecting a technically challenging polyp, to think about having a stable operating field by requesting your anesthesiologist to consider general anesthesia if it can be done safely. So as you can see here, I have not cut out any portion of my hot biopsy avulsion procedure in this patient. To just make the point, sometimes the polyps can be stuck to the wall, and it takes a lot of patience and perseverance to remove these technically challenging polyps. As you can see here again, instead of grasping the tethered area, the biopsy cup actually hangs on to the normal looking area. So keep in mind, before you apply current, you want to make sure that you have the polyp tissue but not normal tissue in your cup. So something to keep in mind. This is something that I've learned during this case because this has not happened before. Given, I suspect that given the scarring of the polyp, this was one of the most challenging resections. So we decided that although we removed the entire polyp, there was still a little bit of tissue here, and we gave our best attempt to remove it with hot biopsy avulsion. But after multiple attempts, a small amount, maybe a couple of millimeters of tissue entangled in the submucosal fibrosis, could not be completely removed to my satisfaction. As you can see here, again and again, when we close the biopsy forceps, the forceps slips on top of that. So as you can see here, we thought that we get it over there, and then it slips. So in cases like this, when I use APC, I focus my attention on the tethered area first, and I want to apply APC to this area till the area is brown. Brown indicates a deeper injury. So that if there are cells in that area that are stuck in the scar tissue, they could be treated by this organ plasma coagulation. The settings that we use here are organ plasma coagulation setting of a flow of 0.8 liters, forced APC set at 35 watts. And I try to use the forward firing APC for all my cases. And it gives me a much better control of applying the APC, especially when I use forward facing APC with a forced APC setting. So as you can see here, after applying the APC to the area that was tethered and could not be completely removed to my satisfaction because there was a couple of millimeters of tissue, we ablated it. We hope that ablation would get rid of this small amount of residual, and hope that we don't have to deal with it on follow-up. So as you can see here, we are completing the APC of the remaining portion of the edge, and this is something that we have incorporated into our practice as part of the routine. And using this protocol of routine APC, we have pretty low residual polyp rate or recurrence rate during follow-up. About 3 to 4% in over 300 cases of patients refer to us to avoid surgery. Again, application of the APC is very controlled, as you can see here, because of a stable operating field by the use of general anesthesia. Something to keep in mind as you do complicated cases where you require a stable operating field, to request anesthesia to provide you with the general anesthesia wherever possible. Even with general anesthesia, sometimes the patients may move, in which cases I request them to paralyze if possible for critical moments of my procedure. So we completed the APC, and we wanted to close the defect with clips. And given the fact that the scope movement was pretty limited because of the angulated fixed sigmoid colon, and above that the colon was wide bore. So using a pediatric scope allowed me to get up there, but with a wide bore colon, the scope can get lost in that wide bore colon. So as you can see here, my movements around this polyp were pretty limited. So given those things into consideration, we tried our best to do the EMR, hoping that this procedure would eliminate her risk of need for surgery. And then even the application of the clips was technically challenging. Usually I apply the clips by keeping the defect in the very low quadrant, but as we apply the clips, in this case, the colon tries to move forwards, and then we have to provide a little bit of a long shot for closure, as you can see here, and also in the previous clip application. So something to keep in mind, and also I want to make it a point here that whenever you have limited movement of the scope and you are resecting it, it is hard to manage the complication like a big bleed or a perforation. In such cases, you may be better off resecting the polyp in small pieces so that you have much better control of any problem that were to happen. So, something to keep in mind. Technically challenging cases, cut small pieces, have patience, and try to avoid getting into trouble. Fortunately, in this case, we did not have any bleeding. Our resection plane was limited to the submucosa, and we did not have any perforation. As I come out of the colon, you will notice in the sigmoid colon the mucosal trauma caused by the scope as we went around this fixed angulated sigmoid to make the point that when you're doing endoscopic mucosal resection, keep in mind how the scope goes through the left colon, and even if you have a small resection, consider closing that to cut down the risk of delayed complications. I hope this video is useful to you. Thank you.